you end up with calcified vessels. Not good. Arteriosclerosis, right? You end up with like buildup in the vessels. They're not going to be as flexible as they usually are. Very bad. Okay? So we try to maintain these things so that doesn't happen. How do we maintain these things? When someone has CKD and not like 1 and 2, you're getting towards like stage 3 plus CKD, you put them on a renal diet. Renal diet means low phos, low potassium also. But for here, dietary restriction of phosphorus, it's not removed really well by dialysis. So you send them to dialysis, you'll get rid of the potassium, you get rid of all those other toxins and fluid and stuff. The phosphorus doesn't come off that well. So you need to make sure they have a low phos diet, limit high phosphorus foods. I have walked into patient rooms and we're like trying to lower the phos, and you look in like their garbage can and you see like a whole box of like certain types of food that have lots of phosphorus in them. So it's not something that the drugs will win. You can out-eat like the medications, right? Like if you have a bad diet, like max the doses of everything, they're not gonna work. You can eat much more than you can get rid of. The medications I'm talking about are phosphate binding agents. So these are drugs that you take when dietary restriction alone fails. Okay, so if you need to give these medications, you give them with the meals. They bind the phosphorus that you're eating. If you give them not with mealtime, you're not gonna bind the phosphorus. It doesn't make sense. Years ago, I had a surgery resident pop in my office, because my office is like surgeons on the floor. Not on the floor, it's figure of speech, okay. So there's surgeons walking by and the surgeon says like, hey, how do I give a phosphate binding agent IV? So we completely like missed the idea. Like this is something that binds the phosphate you eat orally. Like the patient's not eating, no. So there is none, it doesn't work, okay? You need to give it orally with the food to bind the phosphate that they're taking, okay? So administer with meals. You decrease the dose as needed at 2-week intervals based on phosphorus concentration. So there's your goal. This is not a normal phos exactly. This is your goal phos, 3.5 to 5.5 milligrams per deciliter. So if it's too high, you can increase the dose. If it's too low, you can back off on the dose. Okay, and titrate every 2 weeks as needed to get that goal. Different types of phos binders are calcium-containing binders and non-calcium-containing binders. So you're going to start with the calcium-containing binders. When patients have earlier stages of CKD, they have hypocalcemia. This actually can improve their hypocalcemia while at the same time decreasing the phosphorus. But if you give too much, they can now push you the other way and cause hypercalcemia. So you can get hypercalcemia because you actually absorb some of that calcium from the calcium-containing phosphate binder. So if the patient has a calcium that is getting towards the high side, you're going to end up switching to a non-calcium containing binder. So it can improve hypocalcemia, but can push you too far the other way, causing hypercalcemia. So if you need to lower the phosphorus and the calcium is high, you can switch to this non-calcium containing binder. I'll tell you what they are. If there's hypercalcemia, calciphylaxis, there's this calcium phos product. If its number is at least 55, they associated that with worse outcomes. So you take your phosphorus, you multiply it by calcium. If it's 55 or more, you're going to have to bind phosphorus and lower calcium. Okay. So the non-calcium containing binders, calcium acetate is the calcium one. Sevelamer is the non-calcium one. Right. So Foslo is calcium acetate. It's called Foslo because it makes the phos low early. A couple months ago, my student was like, "You give Foslo if you have low phosphorus." I'm like, "No, it's exactly the opposite." Okay, it treats hyperphosphatemia, right? So it takes the phosphate out. Sevelamer is available as 2 salts. There's hydrochloride and carbonate. So if the patient has acidosis, don't give them hydrochloride. It's chloride, but it's acid. So if they have acidosis, don't give them more hydrochloride. On top of that, I've made that interaction a whole bunch of times. That gets missed a lot because people don't read past the drug name and read the salt usually. Right. There's some drug interactions for the calcium ones. You learned about these with like a lot of your antibiotics. So they'll bind, the polyionic cations will bind like 4-quinolones, tetracyclines in your GI tract, and cause a bunch of absorption or drug interactions. Okay. For the other ones, the non-calcium containing ones, there's not really a lot of drug interaction information. Okay. Now I told you that you have to achieve a certain calcium level. Well, not really. The calcium phos product should be below 55. When you're doing that, make sure you correct the calcium if the albumin's low. So the formula's in there. So if the albumin is below 4, you end up doing this equation. If it's above 4, it's not gonna matter. Okay. So corrected calcium, it may look like it's low and actually be normal, or it may look normal and actually be high after you do the corrected calcium equation. Okay. So if hypercalcemia or calciphylaxis or at least 55, switch to non-calcium containing binder. Got that. All right, questions thus far before we get to vitamin D? I have a question about iron deficiency, which, let me get through a couple more slides and I will come back to that. Okay. So vitamin D, the kidneys also affect. Vitamin D comes from a couple of places. It comes from your diet. It also comes from the sun. Most of it comes from your diet, okay? Vitamin D is activated by 2 phases in your body for it to become active. One phase is in the liver. The next phase is in the kidney. It becomes the 125 dihydroxy vitamin D. That is the metabolically active form. So if your kidneys do not work, your kidneys don't let this happen, okay? So you end up having hypovitamin-Dosis or low vitamin D if you have kidney dysfunction. This version of vitamin D may be high, but the one after the kidney could be low. So why does this matter? Well, vitamin D affects most tissues in your body. You see study after study for the last 10 years, it's really like a hot topic about vitamin D being related to falls, being related to dementia, being related to all sorts of cancers, and it really has its hand probably in everything. I doubt that we really understand it very well at this point. Essentially, you want to check someone's vitamin D, and when it's low, you need to correct it. Okay, so you can use ergocalciferol or cholecalciferol. Those are the inactivated forms of vitamin D. They're cheaper, much more commonly used, so use those. If you have a normal 25-hydroxy vitamin D, that's the precursor, that's the pre-kidney one, but you still have an elevated parathyroid hormone, you may need to give the active form. So the parathyroid hormone is sort of the signal that tells the body that it needs more calcium. Okay, so if it doesn't detect enough, or it thinks it doesn't detect enough, it'll be up and you'll end up resorbing your bone and causing these bloating problems. So essentially, you need your parathyroid hormone to be within normal levels, you need your phosphorus to be normal levels, and your calcium to be within normal levels. Vitamin D is one way to do it. So the vitamin D ends up decreasing parathyroid hormone concentrations by lowering your calcium set point. And I'm gonna not elaborate on this because it's more endocrine, okay? What can happen, but when you lower parathyroid hormone levels, you end up increasing calcium and phosphorus. It's like, oh my God, I give vitamin D to lower PTH, but now my phos goes up? The answer is yes. So you have to find a balance of the drugs that is gonna let you achieve all these goals. So you're titrating your vitamin D to parathyroid hormone goals, and you check every couple of weeks in the beginning, and then after they get to goal, you have them come back months apart. It's not like an INR. You don't need to have it perfect. It's just kind of where you want them on a maintenance regimen. There's one more drug called a calcimimetic, cinacalcet sensipar, and this lowers your parathyroid hormone. It's an alternative to the above drugs. It's alternative to the vitamin D analogs. So it's only approved for dialysis though. So if someone is like CKD stage 3 in a patient case I'm giving you, and I have cinacalcet as an option, you shouldn't give it to them. It's only for dialysis, okay? Bless you. Patients that that are given cinacalcet, you're sort of tricking the body to thinking that there's enough calcium. Therefore, you get hypocalcemia. high risk of hypocalcemia. 66% of patients in the phase 3 studies when this drug was approved. So you're resetting the calcium like thermostat or set point, making it think there's enough calcium, so obviously the calcium can go too low. So the dosing is there, and the titration is there for you. There's actually a bunch of drug interactions. So mind interactions for 3A4 and 2D6. Remember, these are probably your two most common pathways for drugs to get metabolized through. So consequences of CKD on other medications. So all medications that are dependent on kidney function for elimination need to be reassessed for dose reduction. So that means the first time you see a patient with chronic kidney disease, every time you see a patient with chronic kidney disease, go down their entire medication list and you need to make sure everything is renally adjusted. So adjust and readjust the dose according to creatinine clearance, okay? If the doses are not correct, if they're dosed too high, they can accumulate and end up causing drug toxicity. Like we said for AKI, the same thing happens with CKD. It's just that now you can go to Lexicomp and see like creatinine clearance of 40, I should use Q12 hours instead of Q8 hours, something like that. AKI, we don't know because we can't use the Cockcroft-Gault equation. CKD, you can, for the purpose of it. So metformin was a kind of an interesting one. It came up earlier. Metformin, historically, from when it was approved, had a dose restriction based on a serum creatinine level, which is very unusual. Most drugs are dose adjusted or restricted based on a creatinine clearance. We saw through a couple of examples that the serum creatinine has many limitations and shouldn't be used alone to estimate someone's kidney function. So you always are going to take someone's serum creatinine, go to the Cockcroft-Gault equation, put it in, and see what number you get, because it may surprise you. You could have someone that the number comes back looking normal, like it looks like it's in my hospital's range, but they're an old patient that weighs very little, and lo and behold, they have a creatinine clearance of like 30 or 40 something, and maybe you should avoid the drug or change the dose. So recently, the FDA changed the dosing recommendations for metformin to update it to have more realistic restriction, not just from a serum creatinine level. So this is from my website if you want to take a look at it. Cefepime, when you look at the renal dosing, this is an example of what we just described, how we handle drug changes in kidney dysfunction. So this actually tells you, look at the creatinine clearance. If it's above 60, this is your dosing. If it's 30 to 60, 11 to 29, less than 11, and you have your different dosing regimens here. The reason there's different columns is because cefepime is used for different types of infections, severe, moderate, mild infections. So some infections you start treating with 2 grams every 8 hours, and then if they have kidney dysfunction, you go down to the appropriate box. All right, so this is actually pretty specific. Other drugs don't have it that specific. I have some more examples. Atenolol you already learned about, right? That has renal impairment adjustment. It tells you if it's more than 35, no adjustment necessary. The 15 to 35, don't go higher than 50 milligrams a day. Less than 15, don't go higher than 25 milligrams a day. These are just some examples. You're going to go down the whole drug list, you're going to see things like this and have to change your doses. Remember our recitation case from hypertension and heart failure? It's a 53-year-old guy. He had a serum creatinine, and we said it was 2.99 with a baseline of 2. So that was kind of tricky. We kind of like skirted away from that and didn't address that really, right? So that patient had, let's see, we'd have to plug in our MDRD equation to see if he had CKD. But I'm guessing if you plugged in the MDRD equation with a 2, he'd come up with some stage of chronic kidney disease. But his serum creatinine today, like when he came into that hospitalization, was 2.99. Is that bad? That's roughly 50% increase from his baseline. So does he have CKD or does he have AKI? What do you guys think? Or does he have both? You can definitely have both. All right, so the term we use for this is acute on chronic kidney disease. So he already had chronic kidney disease, but now he has an acute worsening of the kidney disease, On top of it, this was a patient from like yesterday.